Alrighty, so chapter 3. In the case of chapter 3, blood products, this is a very important chapter, probably one of the more important ones. But to be completely fair, this is pure memorization on most parts, right? But let's just run through it quickly. So all products carry a risk of HIV and hepatitis, except two. HIV and hepatitis are not carried with albumin and globulins, right? Because they're heat treated. Everything else is not. Albumin and globulins are heat treated, which means they don't carry HIV and hepatitis. Donated blood is in general screened for HIV, Hep B, Hep C, HTLV, syphilis, and West Nile virus. So when do you give CMV negative blood? Remember, with CMV specifically, it's an opportunistic infection that really messes with immunocompromised patients, right? And immunocompetent patients barely cause anything, maybe a little mono, right? Not even that sometimes, but or mono. For CMV negative blood, you want to give it to low birth weight infants and any transplant patient, pretty much. It's like bone marrow transplant patient and other transplant patients. So any transplant patient. Type O blood is a universal donor. AB is whatever. Females of childbearing age, right? So females of childbearing age, I don't know if y'all who remember the RH, basically hemolysis. So when you give a female an RH positive blood unit, you are sensitizing her body to RH antigens, which means if she gets pregnant in the future, there's a chance that baby is going to suffer such complications of that, which means you don't want to give her RH positive. You want to make sure any woman, any female of childbearing age gets an RH negative blood unit. Stored blood has low 2,3 DPG. I don't know if you guys remember this, but DPG helps basically blood release oxygen. So when you have low DPG, no 2,3 DPG, that means you're going to have a left shift, which means increased affinity for oxygen, which means it's not going to be giving, transporting oxygen as well. Typing and cross-matching, it is what it is. Screening is the same thing, but for screening, when you say screening, you're including antibodies for minor antigens. 1 unit of packed RBCs increases hemoglobin by 1 and hematocrit by 3 to 5. 1 6-pack of platelets increases by 50,000. So technically, you can just do surgery with 1 6-pack of platelets, you know what I'm saying? Because you need only 50,000 to go into surgery for platelets. Okay, so you have hemolysis reactions and other reactions. Real quick, hemolysis is acute, delayed, and non-immune. Non-immune is when it's literally physical hemolysis, so squeezed blood, In that case, you want to give fluids and diuretics. And whenever we say fluids and diuretics, just think about it this way, right? You want to give, it's like you're washing it, right? You're putting water in it, and then you're pouring the water out. You're giving the patient fluids, and then you're giving diuretics to get rid of the fluids. And using the kidneys basically to filter all that. So you have acute hemolysis and delayed hemolysis. Acute hemolysis is from the ABO incompatibility, right? It's a type 2 antibody, hypersensitivity reaction, right? So type 2 is only antibodies, right? Type 3 is antibody-antigen complexes. Don't think about that. Just focus with me. ABO incompatibility, there's back pain, there's chills, tachycardia, fever. The most important one is hemoglobinuria. That's when you know there's a lot of hemolysis. And obviously there's shock symptoms. And so there's the chills, tachycardia, and fever. It can lead to acute tubular necrosis, which damages the kidneys. It can lead to DIC, and it can lead to shock. The way to diagnose it, basically, is when you look at the haptoglobin, and then you look at the free hemoglobin and unconjugated bilirubin. So with hemolysis, especially acute ones, whenever you have hemolysis, basically with acute hemolysis or any type of hemolysis, if you want to really characterize it in terms of lab work, you talk about haptoglobin being low because it is bound now, and the unconjugated bilirubin being high. And obviously free hemoglobin will be higher. Right, but haptoglobin specifically is going to be less than 50 milligrams because it binds to hemoglobin. Then it gets degraded. Right. Anyways, so the treatment for that is also what? Fluids and diuretics, because you want to fluids and then you want to wash out. The only thing that's different is because you're having such septic or like sepsis or shock, not really septic shock, but like very similar shock symptoms. You want to give pressors and you want to give bicarb, as a buffer. And in the case of anesthetized patients, you're not going to be seeing him. You're not going to be seeing much, right? So the way you diagnose it or the way it presents is by diffuse bleeding, which is very similar to the idea of DIC, because that is a complication besides ATN and shock of acute hemolysis. And then you have delayed hemolysis. Delayed hemolysis is literally increased unconjugated bilirubin, and it presents as jaundice. And that's the only thing you should really know about it for now. You only need to observe for that patient. Other reactions. So this is where this gets good, right? You have febrile non-hemolytic. So it's non-hemolytic, but it's febrile transfusion reaction, and it's the most common transfusion reaction. And because like ABO incompatibility is very rare, and delayed hemolysis is not that important. Non-immune is like squeezed blood. What is that? So when you want to talk about infused reactions or transfusion reactions, you really want to talk about febrile non-hemolytic transfusion reactions. And to make it very simple and very clear, so the patient who's getting the blood has antibodies to the donor, to the blood that's being received, but not to the RBCs, not to ABO, not to the RH, none of that, or HLA. It's to the donor white blood cells. So when the antibodies attack the white blood cells, they destroy them. And when the antibodies of the recipient get the patient who gets the blood attack the donors or the blood's white blood cells, it releases cytokines, right? And this cytokine storm basically causes the symptoms of febrile non-hemolytic transfusion reactions, and you have to use a white blood cell filter for a subsequent transfusion, because obviously you have to still give transfusions. What's the treatment? You don't. The body is basically allergic to the donor or to the blood's white blood cells. Just filter them out, right? And then you have urticaria or rash, and it's obviously non-hemolytic. It's the recipient's, again, antibodies. It's allergic, the recipient is not allergic to the white blood cells in the urticaria. It's allergic to the donor plasma proteins or IgA in IgA deficient patients. Forget the IgA and IgA deficient patients, that makes sense. It's the plasma proteins, right? Because this can be as simple as nuts and other stuff. The treatment for it is obviously histamine blockers like Benadryl and supportive, right? So you want to give antihistamine for this one. Unlike the febrile non-hemolytic, you don't need to give antihistamine. Anaphylaxis is similar to urticaria, but like a much larger scale. Everyone knows anaphylactic shock, anaphylaxis. That's bronchospasm, that's hypotension, that's angioedema, urticaria. Angioedema is really on its own, but it can present with that. It's the recipient antibodies against donor IgA in IgA deficient patients, because this is the one that's like high. Remember how we talked about patients who are IgA deficient? They don't have IgA, which means their body is gonna think IgA is a foreign or like or irregular molecule or protein, which means it's gonna attack it. And when it attacks it, that's what anaphylaxis basically is. It can be an airway emergency, obviously, because of the bronchospasm. So what do you do with anaphylaxis? I don't even have to tell you, all right? Also, besides the epinephrine, you do give fluids, pressors, steroids, and histamine blockers, just so you know. Because everyone's going to think epinephrine, obviously. EpiPen. All right. Here is the most common cause of death from transfusion reactions. And this is where it gets good, right? And this is a theme throughout this book for some reason, at least for me it is. The lung is usually the cause of death for a lot of like variations of disease, and we'll get to that. But if you talk about transfusion related acute lung injury, TRALI, it's very rare. It's donor antibodies. This is the difference. It's not the recipient's antibodies. It's not the person who's getting the blood. It's the person who gave the blood has antibodies to the recipient's white blood cells. So it's kind of the opposite of febrile non-hemolytic transfusion. And what does that do? So the donor's antibodies attack the recipient's white blood cells. It does not cause like leukopenia or any of that like we would think. It just causes an antigen-antibody complex to form clots in the pulmonary capillaries, And this causes non-cardiogenic pulmonary edema in less than 6 hours. So you have ARDS in less than 6 hours from transfusion. And this is the most common cause of death. Other transfusion reaction problems are cold, if there's poor clotting, or in general proteins need to function at a certain temperature. So if it's cooler than that, that's gonna affect their efficacy. Dilutional thrombocytopenia is when you give too many transfusions without actually giving enough FFPs and other stuff like that, and platelets. That's gonna cause dilutional thrombocytopenia. Hypocalcemia, as we talked about, calcium is very important for a lot of coagulation and other stuff, which means if you have you're gonna have poor clotting if you have hypocalcemia. In the case of stored blood, this is very important. Citrate citrate used in stored blood binds to the calcium, which causes the hypocalcemia. The most common bacterial contamination is E. coli, gram-negative rods, and the most common blood product source of contamination is platelets, because platelets is the only one that is not refrigerated, which means it's at room temperature and it's most likely to be contaminated. And for some reason, they threw in Chagas disease, which can be transmitted with blood transfusion. No need to go into what Chagas disease is, just know it can be transmitted with blood transfusions. Not even the most common, but yeah, sure. And that is Blood Products, Chapter 3 of the Absite.